Under the Eighth Amendment, the United States government is legally required to provide adequate medical, mental, and dental care to everyone it incarcerates. But the grim reality inside facilities nationwide contradicts that mandate. Custody mortality rates have spiked in recent years, and states are facing class action lawsuits over horrific conditions and preventable deaths. The people caught in the middle are a rapidly aging, chronically ill incarcerated population and a severely depleted, exhausted correctional workforce. How did the system devolve to the point where it actively endangers both the people living inside the cells and the staff guarding the doors? The collapse of prison healthcare operates like a systemic pathogen. It creates a mechanical feedback loop that tears these institutions apart from the inside. This shifting demographic chart shows the share of incarcerated people aged 55 or older. Over the past few decades, that segment has quintupled, growing from just 3% to roughly 15% of the total prison population. As the data morphs to map behavioral health, we see that roughly 2/3 of the people in jails have a substance use disorder. The medical standard to treat opioid addiction is medication-assisted treatment, or MAT, evidence-based drugs like buprenorphine that stop withdrawals and reduce overdoses. Yet access to even basic care is blocked by administrative friction. Many state prisons charge medical copays of $2 to $5. Since prison jobs often pay pennies an hour, a single visit can cost an incarcerated person an entire week's wages. This forces thousands to skip necessary checkups. If an inmate does see a doctor, strict pharmaceutical formularies often prevent them from getting the right medication. Essential interventions, including MAT for addiction or newer antivirals for hepatitis C, are frequently denied or rationed to save money. Oral health is handled the same way. Preventative dentistry is virtually non-existent, and restorative work like crowns or dentures is classified as cosmetic. The default response to a cavity is to let it decay until the tooth has to be permanently extracted. By heavily restricting routine maintenance, these policies take a population with manageable health needs and turn them into a ticking time bomb of unaddressed ailments. All those neglected conditions eventually funnel into a massive staffing bottleneck. Facilities are operating with staggering vacancy rates among doctors, nurses, and mental health professionals. To keep the infirmaries open, state systems rely on expensive, premium-paid contract nurses and attempt to manage complex psychological issues through brief telehealth calls. This flowchart illustrates what experts call care by crisis. Without the staff to monitor chronic diseases, minor complaints sit in a holding pattern until they break down completely into the red emergency zone. At that stage, the damage is often irreversible. Court investigations have documented inmates pulling out their own teeth to escape the pain, and patients dying from treatable cancers because their specialty appointments were delayed for over a year. This guarantees that the remaining medical staff spend their shifts executing high-stakes triage on patients who should never have become critical in the first place. A medical crisis in a prison requires immense logistical support to manage. Surges in urgent hospital transports and psychiatric episodes severely disrupt normal operations. To cope with the sheer volume of these disruptions while severely understaffed, wardens are increasingly imposing non-disciplinary lockdowns. They confine inmates to their cells 24 hours a day simply because there aren't enough guards to move them. The standard correctional officers left on the floor have to absorb the medical overflow. Guards with no clinical training are routinely forced to manage active suicide attempts, administer first aid, and make life-or-death judgment calls about who gets to see a doctor. The resulting environment is highly volatile. Lockdowns and untreated mental illness spark escalating rates of violence, while officers are pushed to the brink of exhaustion by mandatory 16-hour overtime shifts. This causal loop diagram maps the trap. Unmet medical needs trigger facility emergencies. Those emergencies cause intense staff burnout and mass resignations, which directly deepens the medical staff shortage that started the problem. Medical neglect compromises the basic security, order, and physical safety of the entire institution. Almost everyone incarcerated today will eventually be released. The vicious cycle built behind these walls inevitably crosses the boundary into the public square. When individuals re-enter society physically sicker, psychologically traumatized, and with untreated addictions, their prospects for successful reintegration drop, creating a massive public safety liability. States are now hemorrhaging millions of dollars in forced officer overtime, private medical contracts, and federal contempt fines, all because they failed to proactively fund basic care. Fixing this system is a strict operational necessity. You cannot maintain a safe society if your institutions only know how to punish and lack the capacity to heal.